Wonderful. Okay. Good morning. My name is Dr. Stormy Monks, and on behalf of the Southwest Center for Pediatric Environmental Health, I want to welcome you to today's Grand Rounds presentation. The Southwest Center for Pediatric Environmental Health is one of 10 pediatric environmental health specialty units, also known as PACUs in the U.S. The purpose of the PACU program is to serve as a leading national source of medical information and consultative advice on environmental conditions that influence human health, primarily pediatric development. To serve part of our mission, we are offering this Grand Round series once a month, and it's held on the third Thursday of each month. Today, we are extremely grateful to have Dr. Adiel Aizenberg speak with us on PFAS. But I just want to make sure we have some housekeeping items squared away. You will not be able to share your video or unmute yourself. So if you want to communicate with the panelists, please go ahead and enter your comments in the chat button that's on the right. We would like to also thank our partners at the U.S. Environmental Protection Agency, the Agency for Toxic Substances and Disease Registry, and the American Academy of Pediatrics. Without these organizations, the work of the PACU would not exist. We also want to let you know that we have CME and CNE approved credits available for the series. You must log on and remain for the entirety of the presentation in order to receive credit. If you have any questions about how to move forward to get the credit or get your certificates, please email myself or the other emails I'm going to put in the chat, and we can get that information out to you. I want to let you know that we are having our next Grand Round series on Thursday, September 21st at 11 a.m. Mountain Time. We'll be having Dr. Dalia Neeson, who is works in occupational environmental medicine, joining us. And you can use this QR code to register, or I will be putting the link into the chat as well momentarily. So without further ado, the Southwest Center for Pediatric Environmental Health is very pleased to be joined today by Dr. Adiel Aizenberg. Dr. Aizenberg completed a medical degree at the University of Texas Medical Branch. He is an emergency medicine physician trained here with us at Texas Tech University Health Sciences Center in El Paso, where he did serve as the administrative chief resident. He is currently a second-year fellow in medical toxicology at Banner University Medicine and the Arizona Poison and Drug Information Center. As someone who likes to be out in nature, he believes that we should all be more knowledgeable about how we are impacting our environment. So again, we are very fortunate to have him, and we would like to offer him a warm welcome. Thank you, Dr. Aizenberg, for being with us today.
Thank you, Dr. Monks. Let me share my screen. Does that look good? Can everybody see that?
Yeah. I can see it.
Okay, perfect. So we'll go ahead and get started. I'll be talking about PFAS, and I'll go over what the definition of that is. And this will be a general review. We'll cover different points as it pertains to the subject. I have no disclosures to declare. So learning objectives for this talk. By the end of this talk, we're going to have explained what constitutes a polyfluoroalkyl and a perfluoroalkyl substance and how they are used, what applications they perform. Discuss why these substances are of environmental concern. Discuss why these substances are of medical concern. Review an environmental assessment that was performed after a large contamination event, and detail and review options as to how PFAS hazards can be mitigated and managed. So what is PFAS? PFAS stands for poly or perfluoroalkyl substances, and the difference between those is that per signifies that every carbon is fully saturated with a fluorine molecule or fluorine atom, whereas poly means that it's mostly saturated. So we'll see some pictures of them on the next slide, but it's kind of analogous to triglycerides or a fatty acid chain more correctly, where you either have a fully saturated fatty acid chain or a partially saturated fatty acid chain. The same kind of rules apply. This PFAS describes a large group comprised of over 12,000 different compounds, and due to differences in the chemical structure, they are imparted with various chemical properties. These chemical properties are mainly oil and water resistance and repellent. They reduce friction, and they're temperature resistant, so they can be used as insulators. They're commonly used in thousands of different commercial and industrial products and applications. Some of the ways that we interact with them on a day-to-day basis are non-stick cookware, firefighting foams, and protective gear. They're also in a host of other everyday items. So this is what they look like, the molecular structure. You can see it's a carbon backbone with essentially just all the hydrogens were in a fatty acid had been replaced with fluorine atoms. And then they have this acid group on the end. So it's typically either a carboxylic acid or a sulfonic acid. And they're classified also, not only they're classified by the degree of saturation of fluorine, but the carbon length. So the two biggest ones and the ones that have been most implicated and studied are perfluorooctanoic acid and perfluorooctane sulfonic acid. And you can see that they're both 8 carbons in the chain. So general overview of what these have been used in: everything from the lining of microwave popcorn bags to water-resistant clothing, candy wrappers, shampoo. Firefighting foams is one of the big ones that we'll talk about. So they're in a wide variety of products, generally being applied for the same purposes. It's usually as an oil or water repellent. So we'll go over a historical timeline of how these chemicals came into use and how we've kind of managed or seen them over the years. So in the 1940s is when they were first synthesized. At that time, they were used in nonstick, stain, and water-resistant coatings for various products. In the 1980s, probably earlier than this, they started identifying that there was some potential toxicity associated with these substances, particularly in rat studies, so laboratory studies. In 1999, the first lawsuit was filed against a company making these chemicals on behalf of a farmer named Earl Tennant, who had sold a piece of land to DuPont that was then dumping these chemicals into the land. It was leaching into the water supply, and it was killing his cows. In 2000, 3M which was one of the major manufacturers of these compounds, began to phase them out. In 2001, a class action lawsuit was filed on behalf of a large group of people who had been affected by these compounds. In 2005, a panel known as the C8 Review Panel was formed, and they started reviewing data on health effects of these compounds, specifically perfluorooctanoic acid in Ohio. C8 signifies the 8 carbon chain backbone, so PFO and PFOS is mainly what they're referring to. In 2006, it was found in a variety of drinking water sources, and NHANES, which is the National Health and Nutrition Examination Survey. It's a survey conducted by the FDA looking into basically food dietary habits in the United States and how that impacts health and different endpoints. Started to become aware of these substances that were being introduced into the environment, so they started looking into it. It at least got onto their radar around this point. In 2007, the CDC expanded the NHANES program to start specifically testing for PFAS. At that time, they also found that these two compounds, PFOA and PFAS, seem to be declining in people's blood levels, and I'll have a graph that that shows that. In 2009, the EPA issued a drinking water health advisory for PFOA and PFAS. It's important to know that a health advisory has no legal weight to it. It's just that it's an advisory. So it's essentially a warning, but it's not enforceable. The ATSDR, which is the Agency for Toxic Substances and Disease Registry, drafted a tox profile for PFAS. So that's basically like a compilation of all the latest science and studies that have gone into it, showing how these things are distributed throughout the environment, how we're interacting with them, how we're exposed to them, and how they're affecting us. And then Chemours, which is a chemical company, released a replacement called Gen X, which is just a variant on the same theme as far as the PFAS compounds. In 2010, they started finding elevated PFAS in different people's blood. The EPA in 2012 started requiring that water systems with more than 10,000 people monitor PFAS twice a year during this specific period. In 2013, the C8 panel that had been formed evaluated 17 endpoints and identified 6 potential health links to PFOA. They found more contaminated drinking water. The ATSDR then updated their tox profile, and they put minimum residue levels for PFOA and PFAS. And what a minimum residue level is, the acceptable amount that can be found on a product that is intended for distribution to the public. So what can be considered safe for distribution to the public. Another health advisory was formed later in the decade, and they set a specific number at that time of 70 nanograms per liter. That's specifically in the water supply, and that's cumulative. So if either one or in combination, the level reaches 70 nanograms per liter of public water, a health advisory goes out. But again, these are not enforceable. This is just a warning. And then this Cape Fear River was another big environmental contamination that happened. ATSDR adds PFOA, PFAS, perfluorononoic acid, and perfluoroheptanoic sulfonic acid to substance priority list. And they've been conducting exposure assessments with a big focus near current and former military bases, and we'll kind of go over the reason why that's the case. So this was one of the original articles from Earl Tennant. If it wasn't for him filing this lawsuit and kind of realizing that something was off, these substances, the recognition and the public awareness of these things would have been delayed several years, potentially. Here's the Cape Fear River contamination, an article. It's easy to Google these things and find different articles from the time and what was going on. But essentially, Chemours had been producing these substances and polluting the river, so it was in hundreds of thousands of people's drinking water. In Hawaii, they found them. They're around bases, military bases. They tend to contaminate around there. And then just to illustrate, this is not a problem just in the United States. You can see Japan is dealing with the same issues. It's also typically around military bases, but other countries, the same things apply. Australia, Mexico. You can see how they have surfactant properties, so they're kind of foaming up in the river. This is a map that was put out by the CDC. You can see they differentiate military sites, drinking water, and then other known sites. So it's important to recognize that these are only places that have been tested. So there's potential contamination between all of these dots. It's just that it's not currently being recognized. But you can see military sites are quite widespread in significant areas of pollution, but the drinking water tends to be where large contamination events occurred or around former manufacturing facilities. So why are these things called forever chemicals? You'll often see them referred to as forever chemicals in the news, and that's due to the stability of the carbon-fluorine bond. So these PFAS molecules are stable in the environment. They're resistant to biodegradation, photooxidation, photolysis, hydrolysis. Just because of the nature of the bond, it doesn't break easily, and these are totally artificial chemicals. There's no natural corollary to them, so there's essentially no biodegradation. No, things don't generally metabolize these substances. The bacteria aren't breaking them down. Because they're charged under most conditions that you find in the environment, due to the carboxylic and sulfonic acid, they have low volatility, so they don't off gas, they don't get into the atmosphere very readily. They're small, they're mobile, so they leach, and so they once they get into the soil, they tend to leach into groundwater, and they move through the soil into the groundwater. And so for these reasons and various other reasons, contamination far from the source has been identified in various studies. So the most highly studied compounds are, and the things you may see come up over and over again, are PFAS, perfluorooctane sulfonic acid, PFOA, perfluorooctanoic acid, PFHXS, perfluorohexane sulfonic acid, and perfluorononanoic acid. This is a review of studies that were being undertaken across the globe that was checking levels in different animal populations. Some of them represent apex predators, so the top of the food chain, and so you'll see bioaccumulation potentially occurring in those. Some of those are fish that are commonly consumed in parts of the world. So you can see everything from, I thought there were polar bears on here, but there might not be, but there's ring seals, different types of fish. And this is just to illustrate that these things are found in animals that should have no exposure to these substances. Here is a similar review, but this is all in humans over varying time points. And again, it just goes to illustrate that all over the world, you can see USA, there's China, Germany, these substances have been found from the 1970s into the 2010s, and it's still going on to this day. You can see the NHANES studies included a couple of times here, and these are representative samples of the United States and at different time points. The important thing to note here is that these are not necessarily using the same lab assays, and they're also not using the same samples. So some of them are plasma, some of them are whole blood. So they're not necessarily like apples to apples, but it's more so illustrative of a larger picture. So the pharmacokinetics, once this stuff gets into our body or a rat body, what's going on? So absorption, most PFAS are more than 90% absorbed orally, so they're very well absorbed orally. They're also tend to be highly absorbed through inhalation, but only partially absorbed dermally, depending on the carbon chain length and skin integrity. They distribute serum to whole blood in about a 2-to-1 ratio. They tend to accumulate in target organs. These are largely like endocrine organs, but the liver, kidney, heart, lung are highly implicated. Some of these compounds are highly protein bound. The metabolism, there's essentially little to no metabolism in most animals, but there can be some degree of oxidation under certain circumstances. But the general rule is that there's very little to no metabolism of these compounds. So whatever gets into you stays that way. And if it's excreted as the original compound. The elimination, longer chained molecules tend to exhibit a longer half-life with a extremely wide range in how long they can stay in your body, anywhere from hours to years in experimental and human studies. They tend to be renally eliminated, but there is some fecal elimination with a component of enterohepatic elimination. And specifically in women, there is some degree of elimination through both lactation and menstrual cycles. Due to the differing nature and the different composition of these molecules, they tend to exhibit a fairly wide range of differences in pharmacokinetics between species, sex, and carbon chain length. And then individual factors will also occur. The reason that there's a sex difference, they think, has to do with estrogen levels in women compared to men, and the modulation of certain transporters like the organic anion transporter, which tends to dump these out into the renal tubules, so you eliminate them faster. But women also are eliminating through other routes that men can't. So you can see here perfluorobutanoic acid, half-life on the range of hours. So this is a 4-carbon molecule, whereas PFO and PFAS, which are 8-carbon molecules, are anywhere from 2 to 27 years, and then heptanoic 4 to 35 years. So they tend to stick around for a long time. So human exposure, once these things are out in the environment, how do we get exposed to them? Occupational exposures are known to have occurred. So, excuse me, this is in like factory workers or other people who are working with these compounds. The major exposure pathways for the majority of people in Western civilization occurs through food and water ingestion, to a lesser degree through dust ingestion, and then for certain subsets of the population, namely children, from hand-to-mouth transfer after contact with treated items, the most implicated of which is treated carpets, like stain-resistant carpets. Food can be either contaminated through bioaccumulation, so as it filters up through the food chain and ends up in larger animals that have been eating smaller animals that eat the PFAS, or through direct contact with wrappers that have the PFAS. So like the microwave bags or your to-go containers that are treated with PFAS. And then PFAS and PFOA and various other compounds have been detected in breast milk as well as umbilical cord blood. So this is how you can get exposure during the perinatal and antenatal periods. So you can have, prior to birth, the fetus can have detectable levels of PFAS, but as after birth, there's also specific exposures that occur only in that population. So to touch on placental and lactation transfer, various PFAS have been detected in human breast milk. They've been detected in neonates immediately after birth, in umbilical cord blood and plasma, and in amniotic fluid. There is transfer through breast milk. It seems to be about 10% of maternal plasma levels for some of the compounds that have been studied. And after birth, neonatal levels, the levels in the infant tend to decrease, suggesting that there's a larger exposure in the placenta through amniotic transfer, which then kind of tapers off as the levels decrease after birth. For the majority of cases, this is a general rule. In children, you have that initial in utero and the perinatal exposure from breastfeeding, but then afterwards they're susceptible because of certain behaviors that are specific to children, namely exploratory hand-to-mouth behavior and more time spent near the ground where these things tend to accumulate. In children, there are no sex differences that are apparent, at least not statistically significant sex differences, and that's likely because they don't have these alternative pathways of elimination, and they also don't have the estrogen modulation of elimination. So again, this is another summation of all these different studies that have been done at different time points, looking specifically at this population, pregnant women and children, young children. So you can see that maternal serum after delivery, detectable umbilical cord serum, all these other different specific testing parameters that were undertaken, and over time, how these substances have been essentially detected in these different samples. So at a population level, Most of the studies have shown that there was a consistent increase in body burden from the 1970s into the 1990s. And then there was a gradual tapering off starting in the 2000s with most of the compounds. As a general rule, multiple studies across the globe included cohorts with as much as a 50% reduction in PFOA and PFAS during the first decade of the 2000s. Some studies during this time showed a continued rise in PFNA, and this is the one that replaced PFOA and PFAS. When attention started being placed on PFOA and PFAS, they replaced it with PFNA. So that would be the reason that this trend appeared, and also because of 3M phasing out production of PFAS in 2002. This is a graph by the EPA that was put out, and you can see PFAS. They all tend to decline, but predominantly or the more highly used ones were found, unsurprisingly, to a higher degree in people, and after being phased out in the early 2000s, they've drastically tapered off. So what are the reported health effects? There's a variety of them. In rat studies, they've shown alterations in thyroid hormone and sex steroid levels, so endocrine disrupting effects. There was a consistent display of enlargement of the liver in rat studies. There's evidence of renal and testicular cancers, and for this reason, it was classified as an IARC-2B. IARC is the international, it's a World Health Organization consortium where they classify different chemicals based on their potential carcinogenicity in humans. So 2B specifically means that it's possibly carcinogenic to humans. There's some animal evidence. It's not definitive in humans. There was shown to be a decreased immunogenic response. This is specifically in regards to vaccines. And there was an association with increased autoimmune disease. In humans, there's an epidemiological association with ulcerative colitis specifically. It's important to note that many of these effects are elicited under laboratory conditions where the rats are fed constant high levels of these chemicals. It's not really something that you find typically out in human society. We're not eating high levels of these things on a constant basis, but it's just a way to elicit what kind of effects we can expect from these chemicals. But in humans, there are epidemiological studies that lend some support, but these are not evidence of causality. They're correlation studies for the most part. They released a study a few months ago looking at soldiers from Camp Lejeune, and it was a case control study, and they were looking specifically at testicular cancer, and there was a statistically significant higher level of these things in the subset of the patients that had been diagnosed with the testicular cancer. But again, this is just an epidemiological study in a very specific population. This is a heat map of all the studies that have been performed over a certain time over the last couple of decades. So you can see there's a lot of focus on developmental and reproductive toxicity from these compounds, whether that's because of funding or that's just the avenues that have been explored. I'm not entirely sure, but this is what's been borne out. So when you're trying to apply from an epidemiological perspective, what's your confidence that this compound causes what it is that you're seeing? You have to consider Bradford Hill's criteria of causation. So is there any strength to the association? Is it temporally associated? Is there consistency? Is it specific to the substance? Does it make sense? Is there a biological gradient, which is essentially, is there a dose response? So the more you get, the more of a response you get. At a basic scientific level, does it make sense? Does it happen consistently? Can you reproduce it experimentally? And is there anything that's analogous? And then some people include this criterion of reversibility. So if you take the substance away, do the effects go away? So patient testing, there are no CLIA validated laboratory tests for these substances. So there are no tests, there are no defined reference ranges. Essentially, there are no therapeutic or toxic levels that are validated in humans. The tests that they use are validated to detect these substances, but not for medical use. And it's important to note that any level that you get is not related to outcomes or conditions. The levels under no circumstance influence management decisions, specifically healthcare management decisions. They may influence things like removing somebody from a particular exposure, if you can identify the exposure. And at least up until this point, any blood levels that are obtained are largely for the purposes of surveillance. So this is typically in a study setting, whether it's through the NHANES, another CDC test, or somebody doing an epidemiological study or an exposure assessment. They do water testing. So the EPA has this program where they check for unregulated contaminant monitoring. It's called the UCMR. They test these chemicals at intervals every 5 years, and they specifically focus on water systems, public water systems that are serving more than 10,000 people, but they do include smaller water systems. They're currently on the 5th iteration of this program, and we'll go over what's going to be happening with that. And so you can go back and look at what the results from prior iterations are and how you can go down to the geographical location and what was found in your particular area. So for this iteration, the 5th iteration, you can see they're largely going to be focusing on these PFAS compounds. That wasn't necessarily the case before. They check for various things, anything from pesticides to pharmaceuticals. You can see they're checking for lithium along with the PFAS this year in this current cycle. There is a proposal underway right now. There's nothing exactly enforceable currently as far as how much of these compounds can be in the water, but potentially by the end of this year there will be. So you can see the maximum contaminant level. These are enforceable things under the law. So if they were to test the water and the test came back at over 4 parts per trillion, that's an enforceable level and action can be taken. Whereas this is the maximum contaminant level goal, and ideally it should be 0. This is currently undergoing the process to become enforceable, so potentially by the end of this year. This is just an example of when these things become enforceable, what does it look like? So you can see they have the maximum contaminant level here, and then the health advisory level. Typically the health advisory level is lower than the maximum contaminant level, and that's because a warning should go into place when you start detecting these things at this level, but it doesn't necessarily become enforceable until you reach these levels. And this is also linked to another, the EPA's cancer rating system, and you can see nothing on here is A, but that's a known human carcinogen, whereas B1 indicates limited human evidence, B2 has some evidence. So you can see some of these compounds. So once this goes into effect, if these do pass and there is an enforceable maximum contaminant level, you can expect to see something like this for water testing and other sources of testing. So we'll go through a case of an environmental exposure assessment, what it looks like, and how it's gone through. So first, you have to determine where the exposure is coming from and how feasible is it to eliminate. Is it in the case of this, is it occupational or is it in the home or the near environment? If it's occupational, the best course of action would be to involve an occupational health expert or an industrial hygienist to determine ways of reducing exposure. And this is principally going to be either through removal from the work environment, or through use of personal protective equipment typically. If the exposure occurs outside of work, a thorough assessment will have to determine where the likely exposures occur, and common things being common, you should look at those things first. So things like water, food, any synthetics that are used in the household. And then if indicated and if any questions arise, you can always go to an authoritative source or somebody who does this on a regular basis, such as PageShoe, ATSDR, or the EPA, and they all have numbers and ways to contact them about these things. So we'll go through a case example of an environmental assessment that was conducted. So in Lubbock, Texas, back in 1942, this Air Force base was opened. In the 1970s, they began using this aqueous film-forming foam, which is largely different PFAS compounds, PFOA, and PFAS. The PFAS found in that firefighting foam was then, as over the years, it was entering the groundwater and permeating into nearby wells. So a lot of residents in this area were getting most of their water, their drinking water, from wells. In 1997, the Air Force Base was closed, so this was the last time point that any of this aqueous film forming foam would have been used in the environment in this area. So in 2017, they started detecting PFAS in the private wells that were down gradient from the base. So you can see in beige over here, this is where the base was, and in 2017, they started detecting the PFAS in the wells over here. The Air Force caught wind of this and they started installing whole house treatment systems, so some type of filtration system to reduce the exposure. And they also started distributing bottled water to the community. In 2020, regulatory agencies started getting involved. And so they started testing the well water in anybody, and they also started collecting biologic samples, so urine and blood, from anybody that was older than 3 years, had no medical contraindications to blood collection, and had lived in the area for some time. So you can see here the graph that they were able to derive, and so here's the NHANES data, which is representative of essentially a national body burden, whereas the Lubbock population is the blue bar. So for certain compounds, you can see they were well above the national average. For other ones, they were below the national average. So this is very likely representative of the contamination that occurred at the Air Force Base, and factoring things like how these things were leaching and mobilizing into the groundwater, as well as other potential sources that these residents may have been exposed to. They released this report, so you can see here what these levels were from the manufacturing workers who worked at a facility that were making these compounds in Decatur, Alabama. They were orders of magnitude higher than what was found in a lot of the residents near Lubbock County. So this is indicative of what a workplace or industrial exposure might look like, at least in blood testing. And this is the rest of them. You have the NHANES data from different time points. So from 2000 and again from 2016, and you can see that it's decreased over time in all of them as well. And then you can compare that to local contamination events that have been looked into. So the key takeaways from Lubbock, the levels of these PFAS compounds were at times 4 to 1.2 times the national levels. But again, this was compound specific, and it's representative of what they were being exposed to because of local use and local contamination events. Very likely these levels were linked to drinking the water, but there are other potential sources of contamination that have to be factored in as well. Demographic and lifestyle characteristics were linked to the higher PFAS blood levels. So principally, this is drinking well water. And it's important to note that by the time they started collecting these samples from the patients, all of the well water in Lubbock County was within the EPA's health advisory and the state commissions on environmental qualities protective concentration levels for specific PFAS. So by the time they were checking, so the samples that they collected were more indicative of past exposure, although it is possible that there were other ongoing sources of exposure during this time period. So what do we do about this? What can we do about this? Once you've identified the problem, these things, again, they're not found in nature. Every one of these molecules was created in a laboratory and manufactured at some processing plant. So essentially, we have to reduce exposure, whether that's through limiting consumer products, and this is very much in the population's essentially people are very aware of this currently, so this is becoming much less of a source of exposure, but these things are environmentally persistent, the aqueous firefighting film, and then any past environmental contamination events that have occurred either through spillage from manufacturing plants or otherwise. So it's important to what can we do? Cut off as many of these sources as we can to reduce the endpoint, which is human exposure. There are personal mitigation strategies that are fairly easy to undertake and that we can recommend basically to anybody. You can limit certain foods. This is principally going to be fish, meat, dairy products. You can look into local trends and see if any testing has been done in your area. There was a study that was conducted in New York where they looked at fish consumption based off of different communities within that area. So they looked at a Burmese community versus the rest of the community. And the Burmese community had a higher intake of fish, and this was associated with higher blood levels of the PFAS compounds. In your home, you can use a filter to reduce any potential water contamination. So you can see most of these filters remove a fair amount of the PFAS in the water. You kind of have to be careful about what it is that you're using to filter, because you can see some of these look like they added PFAS to the water, so there must have been PFAS in the filter itself. But whether you're using like a faucet filter or a counter filter or a larger whole house filter, as a general rule, they tend to reduce the PFAS concentration in the water. There are ways to estimate the level of PFAS in your blood. There's no validated test for human application outside of a study setting currently. But if you're able to obtain the levels in your local water supply, you can plug it into this calculator and try to come up with a body burden for yourself. How you interpret that data is kind of up in the air at the moment. So takeaways from all of this, health risks have been identified both through animal and epidemiological studies. The exposure to most of these substances has been decreasing over time, and it's largely a function of where you live and what's been going on in that area. But simple strategies can largely mitigate exposure in the vast majority of situations through filtration or dietary and lifestyle changes. There are new techniques that are underway for trying to either break down these compounds in the environment or different filtration methods to try to remove these in a more sustainable method. There was also a recent study that was conducted in Australia that looked at levels of PFAS in your blood at one time point, and then about a year later, after going through either whole blood donation or serum donation, and the levels did decrease if you had been essentially bloodletting over the course of the year. But again, Whether or not this changes any health outcomes is unclear at this time. And the levels are not linked to any health outcomes. So I think at that point, if there are any questions, I think we have some time to kind of address them or talk about them. Or any points of clarification that anybody would like.
It looks like there's a couple of questions that have come into the chat. This was a few minutes ago during the presentation, but Dr. Aizenberg, are there any clinical symptoms when you'd see a child to consider PFAS levels in your workup?
Currently, no, I wouldn't think so. I wouldn't link any symptoms. Again, there are potential endocrine effects. So if you have thyroid abnormalities and you go through the typical workup and it's not revealing, it might be something to consider. But again, testing for these compounds isn't going to change your management, because the solution, regardless of what the level is to reduce exposure. So if the exposure can be reduced, there's no real role for getting blood work in these patients. You can identify that it's elevated. What you do with that information is not going to change. But again, there are no clinical symptoms tied to these substances. The majority of them seem to be potentially neoplastic, but again, this hasn't been very well established in human through epidemiological data. It's becoming more and more aware, so over the next years, I'm sure we're going to have much more information about how to go about identifying whether what you're seeing clinically can be essentially blamed on the PFAS levels. But currently, I wouldn't blame any symptoms that anybody's experiencing on PFAS. They should be addressed based on a symptom and systems-based approach and treated with the normal standard of care.
Another question that came in, does the Chemours replacement PFAS product X, in quotes, safer than the original?
I don't know that I have an answer to that. I doubt it. It's newer, so there's going to be less data on it, but all of these things, the way that I didn't put a slide specifically on it, but most of them they alter DNA expression is the thought. So they interact with nuclear transcription factors. So, and they might have different binding affinities for it. Some of them might be more potent than other ones, but they're all likely to produce it's most likely a class effect. It's not a specific substance or specific molecule effect. But again, the data is kind of inconclusive on this, and in the next few years, over the next few decades, we're definitely going to have more information on how these things interact with our body and what kind of disease states and pathology we can attribute to them.
Okay, and this one wasn't a question, but more of a comment. I'll just kind of read out in case there's any additional comments that are sparked from it. But important to call attention to the NASEM recommendations of 1 year ago include blood testing for exposed populations and clinical management based on the results. The report provided different patient monitoring recommendations depending on blood levels, and a follow-up comment that is going to be part of the rationale for starting testing at the occupational medicine clinic at the University of Illinois at Chicago. Although their Quest Labs appears to have let's see here. Quest Labs and other commercial labs send clinical samples to their NMS or Eurofins labs, but unclear about the validation of those.
Yes, just to comment on that again, you can detect this stuff in the blood. What those numbers mean is open to interpretation currently. There's never going to be a therapeutic level because these have no medicinal or pharmaceutical use, but like what correlates to a toxic level? What can you expect from certain levels? Um, there's currently no answer to that. So in an occupational setting, it might be one thing because it's obvious it can very clearly dictate your management whether to remove somebody from an exposure. But in your public healthcare settings, these things you're essentially going to arrive at the same endpoint, which is reduce the exposure.
So it's just going to be then similar to what we've encountered from lead and other things, which is just as low as reasonably achievable, but without probably a common true regulated exposure level.
So there with lead, I think when I was reading all of this, it reminded me a lot of lead and how these things were persistent environmental contaminants and how the health effects were kind of ignored for a long time. But now with lead, we have actionable levels. We have health outcomes linked to certain levels. We have ways to we have not only ways to reduce exposure, but we have therapeutic options to try to get rid of body burden to the extent that we can. So if we learn anything or if we take anything from what's happened specifically with lead, I think a similar trajectory can be expected, where at some point certain levels will be associated with certain health effects and there may be therapeutic options. But at this point in time, there are no actionable levels. It's just a level. Is it high or low? And again, it's the same endpoint. It's essentially just doing what you can to reduce exposure in the vast majority of cases.
And one other question that came in is what labs would one order, and is there a total level, or do you need to have specific PFAS compounds individually ordered?
I honestly didn't look into it very in much detail. I know you can test for different compounds. They do in these studies, in these epidemiological and like the NHANES study, they'll test for different compounds. Um, you can potentially narrow down what you're looking for based off of what you think the exposure is. But as far as ordering, if there was if there was a question regarding what else to order, you should order things based off of how the patient's presenting and don't necessarily anchor or attribute these things to PFAS exposure. At this point, it's more of a diagnosis of exclusion than anything else, and I wouldn't even list it as a potential diagnosis at this point since there are no universally accepted or clear health-related outcomes to the PFAS in humans at this time.
I wanted to also let you all know that our region is going to be participating in a multi-region echo series. And so we are combining with regions 1, and when I say regions, I mean EPA regions, I apologize, 1, 2, 4, and we are 6. And the topics covered will be regarding PFAS in drinking water, what it is and what we should be concerned about when a patient is exposed and when your child is exposed, what to do, and then reducing PFAS exposure and environmental justice. And so the plan is to start this ECHO series in October and to do this running through and finishing up in December. So everyone who's registered for this call will go ahead and send this information out to you if you're interested in participating in this next ECHO series that we have. Okay, if we don't have any other questions, I want to thank you, Dr. Eisenberg, again for joining us, and we are very happy that you have decided to continue working with the PACU, and I just again want to thank you, and everyone have a wonderful day.
Thank you, everyone. Thanks for your time. And here are my resources if you want to look at them. And if anybody has any questions about the two specific studies that I just mentioned, I'm happy to send links to those as well. The Lejeune study and the Australian serum studies in firefighters.
All right, thank you again. We'll see you all here next month.
Great. Thank you. Have a good day.